Good morning and welcome to the next session on knee replacement surgery. And the topic today is on how not to do a total knee replacement. Majority of the times and in most meetings, we are taught on how to actually improve ourselves as far as knee replacement is concerned, but today is going to be different. So knee replacement is, my slides are not knee replacement is today a well-accepted management for osteoarthritic knees. We've seen good long-term results. Most issues have been addressed. We've overall got better understanding. We do younger, more active people. And when you look at the data, today 250.2 patients per 100,000 of the population get knee replacements in Switzerland, as opposed to 3.5 per 100,000 population in Mexico. And we expect that about 3 million of them will be done by 2030. And getting it right first time is becoming increasingly important. We understand the mechanisms of failure, and I've listed them just for the sake of completion. And that's why it's probably becoming even more important to know how not to do a total knee replacement so that we can get the best results. My name is Gautam Chakrabarti, and I'm a consultant orthopedic surgeon from Huddersfield. And I have been given the privilege by BIOS to actually conduct this moderator. And for this, I've got two masters and a grandmaster from across the world who are going to present the UK view, the Indian view, and a very senior view, and time permitting, we'll have some clinical cases as well. So from left to right, the UK view will be presented by Mr. Vaisi, the Indian view by Hemant Wakankar, and the Grandmaster, Tim Wilton, will give us absolute pearls of wisdom. Vaisi is a colleague of mine from West Yorkshire, a phenomenal colleague who specializes in lower limb arthroplasty and is presently leading the Leeds Teaching Hospitals Trust and the West Yorkshire and Harrogate group of hospitals as well. For the sake of convenience and to avoid technical problems, I'm going to introduce all three of them at the same time. Hemant Wakankar is from Pune, India. He has got a CV so long that I found it difficult to even condense it into 5 lines. And these are his 5 lines. But the most important bit is 18,000 knee replacements and hip replacements. And that, you will all agree, is a phenomenal number. And therefore, there are lots to learn from him. And finally, our Grandmaster, Tim Wilton. Who doesn't know him in the United Kingdom? He is presently our boss in the NGR, so be good to him. He's been the past president of the BOA, and I had the pleasure of working with him when he was the president of BASC whilst I was the secretary. And I can't thank all three of them enough for giving up their valuable time and energy and effort in participating in this seminar. So Vaisi, it's over to you now.
Gautam, thank you for that introduction. I hope you can see my my screen there. So my name is Vaisi. I'm an arthroplasty surgeon in Leeds, and thank you for the invite to talk on how not to do a knee replacement. And as you say, knee replacements are becoming, we're getting better at them, and it's undoubtedly the case that since we started doing knee replacements, the results have improved. But all you have to do is have a look at the latest publication from PROMS and compare the results of knee replacements to hip replacements to see that there's still a long way to go before our knee results are as good as our hip results. So on the top graphs there, what you can see is that around 50% of people who have a hip replacement report their outcomes to be excellent, whereas that figure is more like 30% in knee replacements. And before I go and talk about how not to do a knee replacement, which is the surgical part of the procedure, I think it's really important to to realize that it's not just about the surgery. And I'm a strong believer that one of the reasons why knee results aren't as good as hip results is that we're not very clear still on who should not be offered a total knee replacement in the first place. And I think we've got to get that right before all our results improve. And the second important excuse me, the second important factor is how not to rehabilitate these patients once they have their knee replacements. And I think if we get those two things right, we will solve a lot of the problems of knee replacements. Having said that, this is about the surgical side of things. And what I'm going to do is just take you through a journey of the things that we can get wrong, and we do often get wrong when we do knee replacement surgery. And I see knee replacements as well as hip replacements as a bit like a game of chess. Every step that you take can have consequences 2, 3, 4 steps down the line, and you have to have a sight and thought about all of these things before you make any of your steps. And that starts right the way from the approach to the knee itself. So when we're making our incision, it's really important that you get that in the right place. And if there are any previous incisions, you've got to beware of the lateral most incision. Don't go medial to a lateral incision. That's how you run into trouble with wound healing. Don't raise flaps. I think this is really important, because a flap that you raise above or superficial to the extensor mechanism is a pocket for hematoma to collect, and you can run into trouble with wound leakage, wounds not healing up, and infection. So keep it simple. Go through the skin straight onto the extensor mechanism and don't raise a flap. And exposure is exposure. It is not a part of the releases that you may have to do during surgery. And I don't think that there's any place for doing the extensive releases that we used to see, where people went all the way around to the back of the tibia to expose the knee. Don't go beyond about 9 o'clock as you look at the tibia from top down. By doing that, you will have adequate exposure of most knees in the primary situation. Having got into the knee, the first thing that most of us do is do the femur. Now, when you're doing the distal cut and you insert your intramedullary rod into the femur, we all think about how much bone we're going to cut from the distal femur. And what we're trying to do is resurface that femur to its pre-disease state. And by and large, you cut 9 or 10 millimeters. One of the things that I always challenge my trainees with is, and I don't know the answer, well, I do know the answer to this, I hope. It's 9 or 10 millimeters from what? And that's a really key question. It's 9 or 10 millimeters from the subchondral bone of an arthritic knee. And if you're measuring from an osteophyte or from a large defect, that 9 or 10 millimeters will not be enough or will be too much. Now, of the two, what I find is that not cutting enough is by far the commonest scenario that you have. And if you don't cut enough, then you will run into trouble later on during the procedure. And I will touch on that in a minute. What I find useful at this point is that in most knees, most knees that we do are varus knees. In most knees, what I would like to have is a bony bridge across the medial and lateral femoral condyles. If I've got that, by and large, I will have cut just about right bone to put a knee in that will function well. We then move on to what I call the most dangerous instrument in the trays that we get given, and this is the sizing guide for our femoral component. I call it the most dangerous instrument because I think this is where most people get things wrong. It does two things. It sets the rotation of the femoral component, and it sizes this, how big the femoral component will be. Usually, we take around a 3 millimeter external rotation compared to the posterior condylar axis. And in most knees, again, this is absolutely fine. In terms of the sizing, I always look at the size that this instrument tells me, and then I put the femoral trial of that size against the cut surface to make sure that I'm not going to overhang on the medial and lateral side, because I think this causes a lot of problems in people. And with modern implants, particularly with the narrow sizes available with most implants, this is less of a problem. But I urge you to have a look at the implant and make sure that you're not overhanging when you measure it. And there's one specific thing that often causes problems, and that's in valgus knees. So if you put your sizing guide against the posterior condyles and you measure the implant that you're going to use, you then have to dial in a bit of external rotation, extra bit of external rotation in valgus knees where the lateral femoral condyle may be deficient. Now, as soon as you do that, the implant size can go up by 1 and sometimes 2 sizes. If this is the case, be really careful about the positioning and the sizing of the implant, and don't take what the sizing jig tells you as gospel. You do have to look at every aspect of the femoral implant before you move on to make your cuts. And one quick tip as to whether you've got your femoral implant rotation correct is to look at the cut surface from the anterior part of the femur. You should have this kind of shape, the so-called grand piano shape, as opposed to a bow tie. If you've got a grand piano, then you have got the appropriate amount of external rotation for that implant. When I come to do the tibia as the next step, I always have a quick look at the X-ray before I start cutting the tibia. I look at how much lateral tibial plateau there is above the fibular head and the rough shape of what I need to cut to get the perpendicular axis to the mechanical axis of the tibia. And usually you have this appearance with a larger lateral plateau excision than a medial. And by and large, if you do that, you will have the correct amount of bone excised and the correct alignment for the knee. We then, having made our cuts, we move on to the trialing of the knee that we have just created. If it's not right during the trial, it will not be right afterwards. So do not think that by cementing your implants in, anything that was wrong during the trial will all of a sudden, by magic, correct itself. And if it's not right, you have to stand back and think. You've got to think about the cuts that you've made. You've got to think about the soft tissues around the knee. And one common mistake that happens is that if you are tight in extension or flexion or both, the immediate reaction is to cut more tibia. Now, I urge you to look at these two pictures here. You can see that the tibia is in play both in flexion and in extension. And therefore, by taking more tibia off, you will affect both your extension and your flexion gaps. Whereas the femur takes part in extension on the distal surface and in flexion on the posterior surface. And by correcting either one of these two parts of your femoral cut, you will affect the flexion and the extension gaps differentially. Don't be lazy. Don't just go for the tibia and cut more tibia off, because that's not always the right thing to do. And by doing that, you will have achieved a balanced knee that works and moves in the way that it should. So in summary, I hope I've talked about how to approach the knee, how to get your cuts right, how you should check, and you should correct anything that's not right appropriately. Thank you.
Thanks, Vaisi. Excellent as always. Beautiful tips. And whilst Hemant is loading up his, sharing up his screen, what we will do is try and take some questions at the end, time permitting. So Hemant, over to you.
Yeah, thank you, Gautam. Thanks for the kind introduction. And it's my privilege to participate in this wonderful meeting. Thanks, Amit, as well, for introducing me to bias. My brief is to talk on some of the aspects of total knee arthroplasty, and especially with the view of what not to do. So without much ado, Mr. Vaisi has already covered many aspects of it. So let me move on. I think intra-op complications, ought to be diagnosed during surgery itself. You don't want to see the manifestation and the disastrous consequences that one may have. And it is quite critical that, one assesses every aspect and every step of the surgery. I consider total knee arthroplasty to be a series of, say, 200 plus steps, and it's possible to get every one of them wrong. And I'm just going to, consider some of them. Here is a disastrous consequence. This patient visited me 3 weeks after having the surgery done elsewhere. And you can see the patient is already, had tunicate palsy, compartment syndrome, and possibly infection as well. You don't want to have that as a consequence for sure. I'm going to touch upon only 3 aspects in my talk here. One is the use of tunicate. Second is the extensor mechanism disruption, especially with respect to the patellar tendon peel. And the third, and that can really be a disaster, can be a medial collateral ligament disruption. So, we ought to consider prevention aspects as well as management if you have any issues. Now, it's perfectly possible to do a knee replacement, knee arthroplasty, without use of tunicate, and especially if a patient is morbidly obese, if somebody has absent peripheral pulses, or you see on a lateral X-ray the calcified femoral popliteal artery, as you can see on the picture here, I would certainly avoid using a tunicate. It's possible to fracture the vessel, especially if it shows calcification in the thigh area. And somebody who has history of DVT or peripheral vascular disease, somebody who has a history of malignancy, I would not use a tunicate. And believe me, it's perfectly easy and possible to do a tunicate. Many surgeons have this mental block about not using a tunicate. So that's perfectly possible. The next is the extensor disruption. And there are some patients who are extremely complex with respect to the exposure itself. Patients who are stiff or have ankylosed knees, who have patella baja, or especially with previous history like high tibial osteotomy. These patients have a difficult exposure. Patella doesn't evert, patella doesn't even sublux very easily. And that does put excessive stress on the patellar tendon insertion on the tibial tuberosity. And one has to be aware, one has to really anticipate that you may have trouble in this. And if you have really excessive tension, then you have to use an extensile approach like a rectus snip, or in some cases of very bad high tibial osteotomy, you need to use a tibial tubercle osteotomy as well. And you need to train yourselves towards these difficult approaches as well. You don't want to see these in a postoperative view where you can see the patella is all flying up, the tendon is disrupted. One way to actually, make surgeon aware of the patellar tendon peel off from the tibial tuberosity is using a tibial tuberosity pin. Mind you, this pin does not actually physically prevent the tendon from peeling off, but it at least makes the surgeon aware of the patellar tendon that can potentially peel off. Because if the surgeon is looking at different, techniques of surgery, suddenly at the end of the surgery, you may find the patellar tendon has peeled off, either partially or fully. As you can see here, the patellar tendon has peeled off partially. And one really has to reconstruct this using either anchors or using osseous non-absorbable sutures, maybe a fiber wire, and really get this strength back on. So that is, I think it's very important. And the last I'm going to talk about is the intraoperative medial collateral ligament injuries. You don't want to see this picture postoperatively, especially as the patient stands up. There are 4 ways I believe you can injure MCL during surgery, and all 4 are perfectly possible. The first one is a stiff knee that is with a fixed varus. And if you have an over-enthusiastic trainee or a registrar who forcibly manipulates this knee into flexion under anesthesia, then this medial collateral ligament does peel off and does rupture. And suddenly you will find that the knee is flexing very easily. In fact, so he may tell you that, oh, knee is now started flexing. It wasn't flexing before surgery. You got to look for the medial collateral disruption. And you should not even try to forcibly anteriorly sublux the knee without adequate medial tibial release, especially true in very stiff knee. The prevention is obviously avoid forcible flexion, avoid forcible subluxation, and one needs to really do adequate medial release. Second is MCL laceration during posterior medial femoral condyle cuts. And one has to protect the medial collateral ligament when one is cutting the posterior condyles. As you can see here, I got my 15 millimeter Homan in the axilla of the medial collateral ligament, and that is the way I protect my medial collateral ligament. I use 2 blades during surgery. One is a 25 millimeter that I use for distal femur and proximal tibia, and second one is 15 millimeter one that I use for posterior condyle, chamfers, and box. You also have to take care while excising the medial osteophytes from the femoral side. The osteotome has to be parallel to the medial collateral ligament, because if you put it obliquely, you can accidentally damage the medial collateral ligament. The third is during laceration during the tibial cut. And I use, again, 1 Homan on the medial side, protecting the medial collateral. And in fact, I use 4 Homans when I'm doing my tibial cut. And the other 3 are obviously protecting the other important structures, and the middle one protecting the medial collateral ligament. So that, I think, is quite important, especially if one is starting off, and one has to look at the length of the blade as well. Sometimes staff nurse may give you an extra long blade, and without realizing, you may just inadvertently go posteriorly and injure the vessels as well. Sometimes one has to do a reduction osteotomy, as you can see here, and as one is doing that, one has to protect the medial collateral ligament as well. That is one of the areas as well when you can easily injure the medial collateral ligament. And fourth is MCL pie crusting. Now, this is a technique that was described by Bellamans, and it's quite popular to get 1 or 2 millimeters of medial release at the end of all your routine conventional releases. This is an extreme, usually for extreme case. And one has to avoid using a number 11 or a 15 blade for MCL pie crusting, because believe me, in just 2 or 3 punctures, you can actually completely lacerate the medial collateral ligament. So instead, one has to use an 18 gauge needle. This is the inside out technique that I'm demonstrating here. But my favorite is actually outside in technique with 18 gauge needle for pie crusting of MCL to get 1 or 2 or 3 millimeters on the medial collateral side. And one actually has to count the number of punctures. I use about 16 to 18 maximum along the length of the entire length of the medial collateral ligament. So the take-home message is one has to be really proactive about MCL protection. I use Homan retractors, and saw plate thickness also has to be critical, and width is also quite important. How to diagnose medial collateral ligament injury? You have sudden laxity or increase in the gaps. And whenever you find that during surgery, especially for a very tight knee that was to start with, and you have sudden laxity or increase in the gaps, you have to check for integrity of medial collateral ligament. And the management of medial collateral ligament rupture is that you really have to complete the surgery using PS implant. That's my preference. Or if you have available, you can consider a constrained implant. The MCL has to be repaired with a non-absorbable suture, either Ethibond or a fiber wire, and has to protect postoperatively with a brace. Consider a constraint process if it is available. Thank you.
Thanks, Hemant. Again, a comprehensive, wonderful presentation. As always, I'm going to thank you. So we now move on to the Grandmaster to tell us the final few tricks before, and hopefully we can squeeze in at least one case. So over to our Grandmaster, Tim Wilton. Thank you, Tim. I'm expecting no less than your normal fantastic presentations.
Well, thanks very much, Gautam. Thanks again to Amit for inviting me. I'm going to try and give you a senior view. I can't really deny being senior any longer. I hope that you're seeing my screen. These are my disclosures. So why are knee replacements failing? Well, in 2013, Lombardi and colleagues said this was why. Wear is no longer a leading cause of failure. Early mechanisms of failure are primarily technical errors, i.e. it's our fault. And these are the main modes of failure in their paper. And I think that we can say that these are the 3 most important. And certainly those 3 are the most important around the world, including our own registry and Australia. And loosening is clearly a very important cause of revision. But this should surely be amenable to improving our technique. Certainly alignment may be critical, cementing technique is important, and kinematic mismatch could induce loosening. So what about bone preparation? Well, if you want to do cementless fixation, precision cuts are really required, and bone debris is positively helpful. But the surface of the prosthesis is critical. If you want to do cemented fixation, perhaps precision is less critical. Cleaning the surface of the bone is really paramount, and a textured surface for the implant is required to get the cement to attach to it. And this has been a mistake in some of the recent implants, such as the Attune, where the first attempt at a tibial component had to be redesigned because it didn't really stick to the cement adequately. So here you see variable bone quality, and actually, although cemented and cementless is an issue, this is a problem for both cement and cementless. And in practice, we find that cementless have a higher revision rate, generally speaking, but this would not be a good scenario for either. Penetration of the cement, if you're going to cement, which most of us will, is really important. And this can be achieved by direct pressure with repeated thumb application onto dried cement after sucking away all of the blood. But cement penetration of over 3 millimeters into the bone improves the loosening rate, and that was proven many years ago by Walker and colleagues. Pulsed jet lavage is really important. This is a really nice tibia which you can clean well. They're not always as easy as that. The sclerotic bone, if you do have it, like on the previous slide, can't allow interdigitation with the cement, and the sclerotic surface is not improved by lavage either. So keyholes are critical in this circumstance, and the strength of keying relates to the width of the cement in the keyhole, not to its length. So we mustn't drill long, thin cement keying holes. We must drill short, fat ones. And certainly all cementing onto any residual sclerotic tibial surface is doomed to cause radiolucency almost immediately. Should we cement the stem? Well, Ritt and Freeman did an RSA study years ago and said that you must cement the plateau, but cementing the stem makes little difference. But they were using a stem which is at least twice as long as those that we currently use, and it was designed to rest against the lateral cortex of the tibia. So that was really probably quite irrelevant to our current practice. Certainly, in vitro studies have shown that it is very important. And if using a titanium alloy tibial component, which I now do and have for a long time, these virtually never loosen if you cement carefully and if you cement the stem as well. So the most common place to find osteolysis at revision is behind the femur and between the femur and the posterior condyle of the femur, often a place which is ignored at the time of the original surgery. So a simple remedy for that is to drill holes there, do pulsed lavage with the knee really flexed, and then apply cement and pressurize it to the condyles before you put the component on. What about coronal alignment? Well, we'll come back to that in the discussion, but I do think that the alignment should allow weight bearing to go through the center of the knee if you can manage it. Should you do 5 degrees valgus or some other, or should you tailor it? We'll again come back to that. But the knee, I think, should be fully balanced throughout the full range of flexion. You can tilt the tibial component to try to release the tension on the medial ligament if you feel that that's important, but this does put the knee into slightly more varus, and I think 2 to 3 degrees is a maximum for that. It's been shown in this paper from Japan that total knees flex significantly less well if you are leaving them with any coronal imbalance, and that's regardless of these other factors which we know affect flexion. How to get better flexion? Well, remove the posterior impingement. If there are osteophytes where the arrow is, take them away, otherwise the tibia will bump into them. Should you use a PS implant? I'll come back to that. But certainly, if you're doing your offcuts, as people showed earlier, you need to measure the offcuts. I measure the offcuts here, and I can show you that this is slightly tight at the back of the tibia on the right, and this means that I've left it slightly tight, and the PCL strain will be increased by that, and the knee will be tight. Should you use a PS or CR? If you're using a PS because you think it gives you more stability, then think again. This paper showed that if you look carefully, you see more mid-flexion laxity if you use a PS knee than if you use a CR one. Also more with a PS knee is a higher revision rate, shown here in blue. And if you really want a high revision rate, you don't resurface the patella and you still use a PS knee, and that gives the red line here. As far as infection is concerned, clean air theatres have been shown to be helpful. IV antibiotic prophylaxis is helpful. Antibiotic-loaded cement is helpful. And any of these three above two of these three above have been shown to be better than one alone. So really, why not do all three things? Discipline is important. Theatre discipline, by all means, use a laminar flow theatre. I think that's a sensible thing to do. You can use spacesuits. Better probably the body exhaust suits than the hoods that blow air into the wound. But above all, keep the instruments inside the area. Don't let them stray outside, otherwise you wreck the whole thing, as you can do by leaving the doors open. Surgical discipline is equally important. Here you see on the left-hand side something which has not been done according to the instructions that we've already heard from our previous speakers, that this skin has been heavily undermined, and on the right-hand side, another one, there it's actually died. Why? Because if you have to raise a flap, which I agree one should try not to do, but if you have to, you need to do it deep to the deep superficial layer of fascia. Otherwise, if you do it here, you're cutting all of the end arteries to the blood, to the skin. So in conclusion, currently, there are definite ways to improve range of motion and function by surgical technique. There are techniques which may improve patient satisfaction independent of the implant used. There's a good reason to believe cementing technique is important. Infection rate is related to theatres, to discipline, and to technique. And the place of compromising alignment to achieve soft tissue balance is uncertain. So how can you screw up? Well, you can ignore those well-established principles. You can adopt the newest implants which as yet have no follow-up data. You can be heavy-handed with the surgery, and you can assume that your instruments or computer or robot know what they're doing and don't need to be checked at every stage of the operation. Thank you for your attention.
Well, Tim, thank you very much. I expected another masterclass. And in fact, it has been 3 masterclasses. Absolutely fantastic. So first of all, what I'd like to do, I am going to see whether we can squeeze in one case, and we are running really short of time. So I shall try and see whether I can share my screen and see whether I can squeeze in one case. That's if I can get to that. I can't seem to be able to share my screen at the moment because it's opening up on something else. I shall try again. Have you got any questions in the meanwhile? Are there any questions in the chat, Martin? Because I can't see any questions. So to summarize, primary osteoarthritic knee, is that the easiest knee to do, or is it the 30-degree valgus where people should start? And your views on use of the computer and the robots, well, the robots now. Tim, we'll go with you.
You want me to answer?
Yes,
my
please.
views on a robot. I think that the place of robots is currently not established. I think that a robot and or computer-assisted surgery of whatever kind is very useful. And I think that the way in which it's useful is the same way in which all other types of instrumentation are useful. I think that if you use the mechanical instruments well and carefully, which involves repeatedly checking and checking that everything you do is actually achieved, then you can get very good results. And I think that instruments and computers and robots may help you to learn what can go wrong and how it can go wrong. But one of the ways that computer-assisted surgery and robots work is that when they do something, they then check that what they've intended to do has been achieved. And sometimes we find that surgeons who are using mechanical instruments don't do that. And in my opinion, that's one of the major reasons why sometimes you see less good results. If I say that I want to cut 9 millimeters off the medial side, off the lateral side, and 4 millimeters off the medial side, and I do my cuts, then I measure those cuts to see whether they've been the same size that I'm trying to achieve. And I think at every stage of the operation, you should be doing that.
Thank you, Tim. I've managed to get, hopefully we can see the screen. Can we see this screen?
Yeah, we can do that.
Yes.
Okay, Hemant, 51-year-old right knee pain in the Western world, to make life easy.
Right. Well, it's quite a significant medial tibial defect there. And if you take a long leg scanogram, you would certainly see that he's got at least 20 degrees of varus, if not more. And I believe this would be a fixed varus. So one has to really be prepared for complete medial release, and even a constrained prosthesis as a backup option has to be kept available here.
Okay.
I don't, when I do my tibial cut in such scenarios, I just take my lateral tibial plateau as the landmark, and whatever defect I'm going to be left with on the medial side has to be built up. And if there is a significant defect in the medial tibial plateau, one may need to add a stem on the tibia. And if one has to release the medial collateral ligament fully to get the balancing right, then one may have to consider a constrained option as well. I mean, I assume that you have the lateral film and, the scanogram done as well. So in a scanogram, you look at your long legs films.
Yeah, and not always is it possible. So in my hospital, it's very difficult because out of 2 buildings, only one can provide that. Vaisi, typical Yorkshire knee this. Nice chubby legs. But the fat is nowhere else except around the knee.
Yeah.
Anything different?
No, not at all. I in a 51-year-old, I might be tempted to see whether I can bone graft that defect by using the lateral tibial plateau rather than using a metal augment.
Okay.
But yeah, I think he will need a stem. Yeah. I'm not sure that he'll need extensive releases. He's got large osteophytes, and by the time you've removed a lot of those femoral osteophytes, I think you may find that that you may not need to do an extensive release on this guy.
Tim, anything else to add? And I'll show you the post-op X-ray.
I think I would use a metal block. I'm not very happy with using bone grafting in this circumstance, but you could use bone grafting. But whichever you do use, I think it's absolutely important, A, not to go down to the level of the bottom of that defect with your lateral cut, and B, to remove the cortical or corticized bone that will be underneath the femur on that medial side, so that whatever you've put in there instead, it can be properly secured with cement. And finally, that was very loosely slung in by Vaisi. Yes, put a stem in it. It will possibly collapse into varus if you don't put a stem in it.
Okay, I've got instructions to bring the session to an end, so I'll quickly show you the post-op X-ray. That is the post-op X-ray. Any howlers in that, or everybody happy?
Looks pretty.
Looks good. I don't like your staples, but yes.
I think it looks very good. I think I probably wouldn't have put it in quite such valgus, because if I didn't, then I wouldn't have to do so much medial release.
Okay. This brings 40 minutes is just to run away. It leaves me to thank all three of you for a massive, massive thank you at a very personal level for all three of you. And I know I've hounded you all a lot trying to get your presentations right and everything else. Massive thank you. Massive thank you on behalf of the organizing committee from Wales and Amit, whom all three of you know very well. And on behalf of the entire BIAS executive, Thank you very much, and have a good day. Gentlemen, I will speak to you personally be outside this meeting. Thank you again.
Thank you.
Thank you.
Good day. Good day. Bye-bye.